I'm starting treatment on the patient, I realize I don't have blood. The patient that I gave blood to this morning received my 1 unit of blood. Hey everybody, my name is Jonathan Scott from Compression Works. I'm the regional sales manager, also an active paramedic. Spent the last almost 10 years of my life working in emergency services in some manner or another. And so I wanted to hop on here today and share with you guys a story about a patient that stuck out to me in my career. And this story happened a couple years ago. I was working on the ambulance in the Houston area. And at the time, the department that I was working for, we had one ambulance unit. We carried 1 unit of blood. Early that morning, not before breakfast, we had went out to a nursing facility in our district, and we had treated a lady for a GI bleed. She was pretty sick, needed blood. She was alert, but just bleeding really bad. We had a hemoglobin on her, found it to be low, so we gave her our unit of whole blood. Patient did fine. She goes to the hospital, not a problem. Not too long after breakfast, we get a call for basically an unknown hemorrhage. So we pull up beside the vehicle, and there's someone standing there outside the vehicle, kind of motioning towards us to the back seat. So I get up to the back seat and I open the door. The first thing I'm greeted with is the smell of blood. For those of you that have worked on the ambulance and been in pre-hospital healthcare or even worked in the emergency room, you know when someone's bleeding really bad, because blood has that iron in it, that metallic smell almost when there's a lot of it outside the vasculature system. As I look down, I notice that in the floorboard of this SUV, there's quite a bit of blood. Enough blood to completely cover the carpet and the floor mat to the point where I can barely see it sticking up on the edges. Our younger female, probably in her 30s, sitting there, and she is in obvious distress. She's very diaphoretic. She's very pale. And I look over in the seat, and I see a baby in the car seat on the other side of the vehicle, very obviously a newborn, very small child. And so start to put two and two together. Hey, we're on our way back from the birthing center. We just gave birth a little while ago, and she started to have a massive vaginal bleed, started to have a postpartum hemorrhage, what we now know as a postpartum hemorrhage. On her, I was feeling for a radial pulse. I didn't really feel one, but she's kind of talking to me a little bit. We're getting the stretcher up to the door, and I look at her. She's wearing yoga pants. And as I look at her yoga pants, I can tell that there's like clots trapped inside her yoga pants, and almost like around her calves had like the consistency of Jello. So I was like, man, this lady's bled a lot. This is not good. I get on the radio and I say, get the supervisor unit over here, and because we're going to give this patient blood, she obviously needs blood. This is a major bleed. We get her on the truck, and about that time, as I'm going through treatment plans, my partner's getting an IV, I'm starting treatment on the patient, I realize I don't have blood. The patient that I gave blood to this morning received my 1 unit of blood, which was the right thing to do. Don't misunderstand me. But now I've got this patient that also needs blood that's in a bad way. We understand that blood is a finite resource. There's a finite amount of blood in the human body that can be lost before a patient goes into traumatic cardiac arrest or irreversible shock. There's also, from an EMS operations standpoint, there's also a finite amount of blood that is available to be administered. Depending on which department and where you work, you may have access to 0 units. You may carry plasma or some PRBCs, or you may carry 1 or 2 or 3 units or 4 units if you work for a large agency across your system, but it's still a finite amount, right? I remember being in EMT school, my instructor telling me, he said, well, all bleeding stops eventually. While that may be humorous in a classroom setting, when you have a patient that's laying on your stretcher that you can't control their bleeding, it's not a humorous statement, because that bleeding will stop and that patient will die on you. We got this patient to the hospital, got her some fluids, got her blood pressure up, got her taken care of. We never did actually control her bleeding very well pre-hospital in the pre-hospital sense, but we thankfully were very close to level 1 trauma center and were able to get her taken care of. But in my career, I haven't always worked 5-10 minutes away from a hospital. I remember working in rural Arkansas where, depending on which side of the county that you were on, you oftentimes are over an hour away from the trauma center. And so I'm just thinking, how do you manage these patients? What can we do? We, as a paramedic in a pre-hospital sense, we can't place an intrauterine balloon or a Valkyrie balloon. A lot of us don't carry Pitocin or don't carry advanced drugs, pharmacology, and things that will work um, sometimes, right? And so we don't have the benefit of that. So we're stuck with a fundal massage, treat their blood pressure, evacuate their clots, and get them to the hospital as quick as you can. Well, if you're bleeding from the uterus and you're an hour from the hospital, depending on how bad the bleed is, you're not guaranteed to make it there with a patient that's alive. As I started to work for Compression Works, I remembered this call. This call stood out to me because it was a patient that I had used my blood. I had no blood to give her. She was bleeding very badly. I couldn't control it. My fundal massage wasn't working. So I couldn't really treat this patient other than give her some fluids and hope we could get her to the hospital fast enough. And so as I started learning more about the AAJT-S, learning about the physiology of what the device does and how you can apply the device on the navel and turn blood off like a faucet through the abdominal aorta before it ever gets to the uterus, before it ever gets to the pelvis, that resonated with me because I thought back to this call and I was like, man, if I would have had a device like that, I could have treated this patient and stopped her bleeding, and I could have handed the facility a far more resuscitated patient, a patient that's far more ready for surgery and stable and for imaging than I would have if I just, let her free bleed, which is ended up basically what we had to do until we could get her into the facility. Think about what your treatment would be if you had that patient. What's your average response time to the hospital? How long does it take you to get to definitive care? And then ask yourself, how long can my patient bleed? Is the blood on my unit that I respond to with, or do I have to wait on it to get there? What can I do in the meantime before blood arrives, or maybe it's too far for blood? I think it's really where the AAJT-S shines. It's the only truncal abdominal tourniquet on the market. And so I think giving these patients advanced hemorrhage control, what they need to be successful, what they need to get to the hospital to survive, I think is, as a provider, one of the most beneficial things that we can do, and it's what we're put on this planet to do. Thanks for coming to my TED Talk. I appreciate you taking time to listen to my story and a little bit of my ramblings. But you can go online at www.compressionworks.com and you can learn more about the AAJT-S as a junctional and truncal tourniquet. Thanks. Have a great day and stay safe.